Hello everyone, welcome to the first video from Easy RadOnc. Today I'm going to give you a small intro on radiotherapy. Let's start. Radiotherapy is the use of ionizing radiation to treat diseases, usually cancer. So we just give an ionizing radiation and we just kill the cancer cells. So there are four different intents of RT. Intent means your objective. The first one is radical, where the objective is to cure, often with chemotherapy. Along with chemotherapy, you're also giving radiotherapy. The next one is adjuvant, where your goal is to reduce the recurrence. It is mostly multidisciplinary. Oncology is made of three teams. Medical oncology, where they use chemotherapy. Surgical, where they just remove the tumor if possible. Radiation oncology is which I am now talking about. Now, coming to the third intent, that is palliative. The intent is not to cure, but to reduce the patient's symptoms and suffering. We can't do much, so we'll just at least reduce the symptoms and the patient's suffering. Coming to the last part, that is neoadjuvant. Neoadjuvant is where radiation is given prior to surgery. This is like to reduce the tumor bulk so that it's easy for the surgeon to operate. Now, if you see radiotherapy is available only in tertiary care hospitals. There are three types of hospitals: primary, secondary, and tertiary. Primary is where you go for like normal things, for example, common cold or fever or like that. Secondary is where they refer you from primary if they are not able to treat you properly. Tertiary is the last option. Tertiary is where you have those multi-speciality teams, these bigger hospitals. Treatment is mainly on OPD basis, sometimes IPD, depending upon the scenario. Now, the beauty of radiotherapy is it is of no pain, it is silent, and it is invisible. Unlike chemotherapy, where the patient is bound for some toxicities, surgery, as you know, surgery takes a lot of pain, a lot of time. So, radiotherapy is, in this aspect, it is somewhat better than all the two combined. So, how does radiotherapy work? So radiotherapy is mainly of two types: photons, where we give high energy X-rays. These high energy X-rays penetrate into the tissue. They produce secondary electrons from the tissues and cause secondary damage. Whereas electrons, they directly reach the cell and cause DNA damage. These are produced by devices high-end technology, advanced technology, that is called linear accelerator. Now you must be wondering, won't the normal tissue also get affected? Yes, but they recover faster by repairing. Normal cells repair the damage quickly because they have proper repair mechanisms, whereas cancer cells have a defective repair mechanism and they die out quickly. That is the basis of radiotherapy. The basic unit used in radiotherapy is gray. RT is delivered in split doses called as fraction. The number of fractions and the dose depends on the type of treatment and the disease. Now coming to the aspects of RT. So how do you take a patient who has come for radiotherapy? This involves the following steps. First, pre-treatment. First, we take a detailed clinical history and we examine the patient so that we can come with the clinical findings. Then we send the patient for imaging and to confirm the diagnosis. Then we get the patient consent for radiotherapy. Then we immobilize the patient using cast, which I'll explain later. Then we take the patient for a planning CT scan. Then coming to treatment planning. Using the planning CT scan, we delineate the tumor and organ at risk. Delineate, we just draw the organ, the boundaries, so that we can distinguish between each organ, and each organ has their own dose, like dose limiting doses. Then we calculate the dose and we plan. This goes to the physics people. The physics people carefully calculate the dose and they plan accordingly. Then the whole team discusses and reviews the plan. Then comes the treatment delivery. The patient comes for daily treatment except for Saturday, Sunday, which is usually an off period. Then during the treatment, we verify and check whether the patient is receiving proper treatment or not. And also during the treatment, we review the patient clinically on an OPD basis. Then the patient completes the treatment. Then we will do follow-up. follow up so that we can know that whether the patient is off the disease or still we need to work on it. Coming to immobilization. Immobilization is where a thermoplastic cast is used to immobilize for precise treatment. Let me explain this sentence. The basis of immobilization is not to make the patient move. We are giving radiotherapy. So if the patient moves, the radiation might go to vital organs, like for example eye, and the patient might go born for effects like cataract, radiation-induced cataract. So we use something called as thermoplastic cast. These casts in higher temperature assumes a plastic shape, and as the temperature reduces, it becomes elastic, where the cast tightens. So we heat the cast to a certain degree, then we just apply the cast over the patient and we wait for some time so the cast takes the shape of the patient. It is not very tight, it is not very loose. That's the main point of treatment, not to make the patient move and to make him or her more comfortable. Other immobilization devices such as vacuum bags are used to immobilize other body parts. So some patients, they are unable to lie down properly, or they can't move, or they can't like for some other reason. So what we do, we have a separate device called the vacuum bag here. This vacuum bag is used to take up the shape, and at the end, we make sure that the patient does not move. That's the only objective here. Now, the picture shows a CT simulator. This is very different from the diagnostic CT, which you might have seen or which you might have heard about. The only difference is that we use this to position the patient correctly and so that we can reproduce this exact position during the treatment. The word simulator is self-explanatory. So the difference is here we have markings on the side so that we can account for accuracy. So here is a patient who is positioned in a CT simulator. In this procedure, what we will do, we just adjust the patient correctly and we do something called laser marking. Laser marking is where we mark the patient according to the landmark, important landmarks which is near to the tumor. So they get usually two markings on the side and one at the top. For example, in this patient, which is a head and neck cast here, so what we do, we mark the patient here like this, and also on the other side, two at the side and one at the top, so that it becomes very easy to reproduce the exact setting during the treatment. And since it is delivered in fractions, so every day we have to be very careful while treating this patient. Now let's see how the planning is done. So we need to take account three volumes. Take a closer look at this diagram. You can read this. Gross tumor volume, clinical target volume, and the planning target volume. Now let's talk about this. Gross tumor volume is where you can visually see the tumor in this planning CT. Or when the tumor is removed, it's where you can see the cavity. Okay. Now a tumor does have some microscopic extension where you cannot see the tumor, but there is tumor present. So to account for this, we have something called the clinical target volume. Now next, planning target volume is where you account for the daily variation in the setup, the treatment setup. So every day you are giving like 2 weeks of radiation. Now there has to be some little like around here and there. There's some variation. So in order to account for that, we do something called planning target volume. Now this is a clear demonstration of all the tumor volumes in real-time planning CT. You can see the GTV, the PTV here, and the CTV here. And you can also see there are other organs which are also delineated here. This is the reason why they are doing is because for delivering the doses which is under the recommended dose constraints, which I'll talk about in further classes. Now this picture shows an example of a linear accelerator where either photons or electrons are delivered. A black couch with the marking same as the CT simulator is there to reproduce the exact position for accuracy. For 2 weeks, you have to do the same thing. So that's why the markings are similar to the CT simulation. The circular thing which you see here is a gantry where the head rotates 360 degrees. Why this reason is to give multiple beams which are used to angle around the patient to conform to the tumor. Now, talking about toxicity, this is just a transient damage to normal cells. It gets repaired with some time. Now, let's discuss each toxicity one by one. Now, coming to the first one, which is mucositis. Mucositis is just the inflammation of the buccal mucosa here. So this is managed by analgesics, oral hygiene, treatment of infections, and proton pump inhibitors. Now, coming to the second one, radiation dermatitis, which is just the inflammation of the skin. You can just manage this by hydration, ointments, topical steroids, no sun exposure. Cystitis is the inflammation of the urinary bladder. This is managed through NSAIDs. For irritative voiding symptoms, anticholinergics and antispasmodics are used. Now coming to neurological part, this is managed by just corticosteroids and anti-epileptic drugs. Now the respiratory part, it is managed through bronchodilation, treatment of infections, and judicious use of corticosteroids. Now cardiac management. Management through acetylsalicylic acid and colchicine. Sometimes antiarrhythmic drugs, which depends on the situation, and treatment of heart failure. Now coming to GI, the most common is diarrhea. It can be managed by antidiarrheals and the treatment of infections. Now this shows oral mucositis. You can see it here, and you can see radiation-induced dermatitis. This is a clear demonstration of all the toxicities which you usually encounter with radiation therapy. Now let's discuss about chemoradiotherapy. We give chemo along with RT to increase the effect of the radiotherapy. However, it runs the risk of increased toxicity, and over that it also severely decreases the neutrophil count. So we need to manage the patient very carefully, and it is given only in select like young people who can tolerate chemo and also radiotherapy. And this ends my small talk about the basics of radiotherapy. If you feel this lecture is good, please don't forget to subscribe, like, and share. Thank you so much.